Leg deformities in children. In towing and out-towing.
Leg deformities in children. In towing and out-towing.
This video has been produced from a book source of Netter's Orthopedics. We would like to thank to editor Walter B. Green. All of the authors owe a great debt to Frank H. Netter, M.D., the medical illustrator who created the majority of the illustrations in this book. The oft-quoted statement, "Children are not just small adults," is particularly germane to the diagnosis and treatment of pediatric disorders of the musculoskeletal system. Growth and its associated remodeling potential may be a tremendous ally in the treatment of some pediatric disorders. For example, in a newborn with a dysplastic dislocated hip, simple splinting often results in a normal joint that provides normal function for a lifetime. Growth, however, may exacerbate some conditions. Excessive pressure on a growth plate, particularly one that has some dysfunction, causes further inhibition of growth and progressive angulation of the limb. Examples include progressive genu varum observed in infantile tibia vara, rickets and other skeletal dysplasias, and progressive curvature of the spine as observed in some pediatric spinal disorders. Erosion of articular cartilage caused by skeletal malalignment takes time to develop. As a result, severe pain from skeletal deformities often is absent during childhood. An understanding of the natural history of these conditions is critical for knowing whether observation, bracing, or surgical treatment is needed. Furthermore, the lower extremity undergoes changes in alignment during growth. An understanding of these physiologic changes is necessary before it can be determined whether a child is normal for age or needs further evaluation. This chapter reviews the angular and rotational changes that occur during growth, as well as genetic diseases that affect skeletal growth and function. Juvenile rheumatoid arthritis, pediatric and neuromuscular disorders, infectious disease, tumors and childhood disorders localized to a specific site are described in other chapters. In towing and out-towing. Intrauterine packaging influences the position and alignment of the extremities, particularly the lower limbs. Neonates have moderate hip flexion, abduction, and external rotation contractures, mild knee flexion contractures, and excessive ankle dorsiflexion. With more room to move, the infant typically stretches out the knee and ankle in a few weeks. However, hip external rotation capsular tightness does not resolve fully until the child begins to walk. In towing and out-towing are common parental concerns after a child begins to walk. In towing, the more common concern may be secondary to increased internal femoral torsion, femoral anteversion, increased internal tibial torsion, foot deformities, or some combination of the three conditions. Out-towing may be secondary to external femoral torsion, femoral retroversion, increased external tibial torsion, foot deformities, or some combination of the three conditions. An understanding of normal development is critical because in towing and out-towing are frequent variations of normal development. Femoral torsion, anteversion, is greatest at birth, approximately 40 degrees, and gradually declines to adult values, 10 degrees to 15 degrees, by age 8 years, figure. Although it does not provide an absolute measurement, the easiest way to assess femoral anteversion is through measurement of hip rotation with the child prone and the hips extended. However, it is important to realize that clinical measurement of hip rotation does not profile the degree of femoral torsion until the neonatal hip external rotation contracture fully resolves, which usually occurs by 1 year of age. However, it may take longer. In children, the total arc of hip rotation is typically 80 degrees to 100 degrees, and the average range of rotation for a child older than 2 years is approximately 50 degrees internal rotation and 40 degrees external rotation. Increased internal rotation coupled with decreased external rotation indicates increased femoral anteversion. Likewise, increased external rotation coupled with decreased internal rotation indicates reduced femoral torsion, femoral retroversion. Femoral torsion is within normal limits unless internal or external rotation is less than 20 degrees. Tibial torsion, measured by the relationship of the transmalleolar axis to the coronal axis of the proximal tibia, is typically neutral, or 0 degrees, at birth and gradually increases to approximately 20 degrees by age 10 years, range 0 degrees to 40 degrees. Tibial torsion is often asymmetric, with the left side commonly less externally rotated. Although it is not a direct measurement, tibial torsion also may be assessed through measurement of the thigh-foot angle, figure. This angle is easier to measure and parallels the transmalleolar axis, but average values are typically 5 degrees greater internally. Parents often seek medical attention for their children because of concern about how they are walking. Children with severe in-toeing may stumble or trip more frequently as they catch their toes on the back of the trailing leg. Neuromuscular disorders also cause in-toeing or out-toeing, and children with these conditions, most often mild cerebral palsy, may be brought to the physician for evaluation of the abnormal walking before the underlying neuromuscular disorder has been diagnosed. Therefore, children undergoing evaluation for in-toeing and out-toeing should be screened for development of appropriate motor milestones, table, and examined for spasticity, muscle contractures, and a stiff or unbalanced gait. Physical examination should include the following steps. Measurement of foot progression angle, the angle that the foot makes relative to the line of progression as the child walks. Measurement of hip rotation, femoral torsion. Measurement of tibial torsion, thigh foot and ankle. Inspection of the foot. Evaluation for possible neuromuscular disorders. The foot progression angle does not indicate the site of the problem, but it quantifies the severity of the problem and distinguishes it as either in-toeing or out-toeing. By age 2 years, children typically walk like adults in that the foot is turned out relative to the line of progression. A normal foot progression angle is 10 degrees, range 0 degrees to 20 degrees. Metatarsus adductus and clubfoot are foot conditions that may cause or contribute to in-toeing. Increased heel valgus, typically associated with pes planovalgus, may contribute to out-toeing. External rotation contracture of the hip during infancy may persist to a degree that causes concern when the child is between the ages of 6 and 12 months, a time when limb alignment is more obvious because children are in walkers or are starting to pull to a stand, figure. Associated factors include male gender and black race. Examination typically reveals 60 degrees to 70 degrees of external rotation and only 20 degrees to 30 degrees of internal rotation. Hip rotation is usually symmetric, but out-toeing is greater on the right because tibial torsion is usually more external on that side. Most children who exhibit in-toeing after 2 years of age have increased femoral anteversion. Regardless of the source of the in-toeing or out-toeing, however, most children with these conditions do not require treatment. Shoe modifications, braces, and exercises do not alter the development of femoral or tibial torsion. Casting occasionally is necessary in metatarsus adductus. In normal children, enough correction or compensation for increased femoral and tibial torsion occurs so that walking and running are not adversely affected. Although uncommon, if the child is 8 to 10 years of age and the in-toeing remains severe, then a rotational osteotomy of the femur may be indicated. Patellofemoral tracking problems occasionally result from increased femoral anteversion and concomitant external tibial torsion. With persistent knee pain, this so-called miserable malalignment syndrome requires corrective osteotomies of the femur and tibia, figure. In children with cerebral palsy or other neuromuscular disorders, abnormal femoral and tibial torsion is more likely to persist to a degree that requires surgical correction.
Thanks for watching. Please subscribe to my YouTube channel. Thanks for watching. Please subscribe to my YouTube channel.